Hello, welcome to Chapter 15 of Lifespan Development, Physical and Cognitive Development in Middle Adulthood. In this chapter, we will look at physical changes, health and wellness, and cognitive functioning. These are the objectives we'll be covering this week. First of all, let's look at physical changes. Development is more an account of differences than of universals. Remember, we've talked about before, primary aging is more universal. It's stuff that happens just because you're getting older. Secondary aging is dependent on your habits. Earlier habits have a strong effect on aging in the aging process. For instance, smoking, drinking, or choosing whether you choose to do exercise or not. However, there's more research that's needed on midlife. Cognitive tasks activate a larger area of brain tissue in middle-aged adults. In other words, us middle-aged adults use more of our brain when we think. Cognitive processing may be less selective with age. Middle-aged people process sensory stimuli differently. For instance, experiencing problems with attentional control. But although this goes on, we still are safer drivers than younger adults because of experience and because of impulse control. When middle-aged and young adults are compared, the range of individual differences within each group is far greater than the average difference between the two groups. And participants in both age groups who perform poorly on tasks such as remembering words, larger areas of the brain are activated than those who performed well. Behavioral choices and mental health affect the brain. Our circulatory system health affects parts of the brain involved with memory, planning, and processing speed. Let's talk about sex. Climacteric is the loss of our reproductive capacity. There's a slight decline in the quantity of viable sperm produced in men. A very slow drop in testosterone causes this. Causes a gradual loss of muscle tissue, increased risk of heart disease. Lifestyle changes such as weight loss and exercise can restore some of these problems, such as erectile dysfunction. Performance anxiety increases, causing erectile dysfunction. Now, Viagra is a common treatment. You've probably seen that a lot on advertisements 24/7. Menopause in women occurs roughly at the age 50, though anything between 40 and 60 is normal. The cessation of menses is due to declines in sex hormones of estrogen and progesterone. It may be occurring at later ages in more recent cohorts of women. That's a secular trend that menopause is happening later and later. Premenopausal phase is when estrogen levels begin to fluctuate and decline. The menstrual cycles without ovum are more common. There's a dramatic drop in progesterone production. Next is perimenopausal phase. There's more extreme variations in the menstrual cycle. Hot flashes, sudden sensations of being hot. Of women in this phase, 85% will have hot flashes for more than a year. 1/3 for as long as 5 years. Skin temperature can actually rise between 1 and 7 degrees and can be elevated for about 3 minutes. Hot flashes frequently disrupt sleep and may cause sleep deprivation in many women. And sleep deprivation can generate psychological distress. Postmenopausal phase is when a woman has stopped their menstruation for 1 year. Estrogen and progesterone are very low. Breast tissue becomes softer. The uterus becomes smaller. The vagina becomes smaller, thinner, less elastic, and it produces less lubricant. 2 letters, KY, is why middle adults are very grateful. Next is hormone therapy, or HT. And it's where doctors may administer progesterone and estrogen to try to keep more of a balance. The Women's Health Initiative study came up with a protocol and findings for use of hormone therapy. There's a nice little video here, my psych lab video on estrogen and memory and how that affects. Results from the Women's Health Initiative in 2002. The pros of hormone therapy: it reduces hot flashes and protects against osteoporosis. The cons of hormone therapy is long-term use is related to risks of breast and ovarian cancers. And there's no protection against cardiovascular disease. So you decide. Due to the risks involved, hormone therapy should be a last resort for menopausal women who have hot flashes and other symptoms, or just keep in mind no medical treatment is entirely free of risks. So women who want to take hormone therapy to relieve symptoms of menopause should be able to do so. Some women have even went as extreme as having what's called a hysterectomy as a treatment. Psychological effects of menopause. Research is mixed regarding menopausal effects. Negativity and overall life stressors affect our moods as well. It's important not to tell a woman that their behavior is because of menopause or because of their menstruation. Severe symptoms of sleep deprivation may be related to the additional anxiety. Depressive symptoms may increase, but longitudinal research shows no relationship between menopause and serious depression. Also, ethnicity can influence a women's attitudes about menopause and aging. Some research has shown that African American women are less concerned about menopause compared to other cultures, ethnicities. Most women remain sexually active, although the frequency of activity declines somewhat. Demands of other roles are pressing middle-aged adults, so they have less time for sex, child rearing and all that. But increasing illnesses such as diabetes and arthritis may also explain declines in sexual activity. Osteoporosis is where which begins around age 30 for women and men. It's where there's reduced bone mass. The bones are more brittle and porous, can cause bone fractures. This is linked to a loss of estrogens and progesterone in women. That's where hormone replacement therapy may help. Getting sufficient calcium early in life helps. Regular weight-bearing exercise helps, and new bone-building medications can help. Menopause accelerates bone loss. Significant increased risk of fractures occur in women after 50. Osteoporosis is a primary aging factor, but individual differences do occur if you look at table 15.1, page 381. If you look at this, it shows how race, whites are at higher risk for osteoporosis. Women have considerably higher risk than men. Those who are overweight are at higher risk. Women who experience early menopause and those who have had their ovaries removed are at higher risk. So that's a lot of times when women will have a hysterectomy, they'll keep their ovaries there. If there's a family history of osteoporosis, they're at higher risk. Diet also can affect the risk, and exercise. Having a sedentary lifestyle and no exercise puts them at higher risk. Now here's some new words. Usually at my age, you start experiencing loss of visual acuity. There's presbyopia, which is farsightedness. It's because the lens of the eye thickens and the total amount of light reaching the retina decreases. It's harder for the muscles around the eyes to change the shape of the lens and adjust the focus. So part of primary aging requires physical and psychological adjustment. You have to wear glasses. Next is presbycusis, and this is a loss of hearing. The auditory nerve and structures in the inner ear gradually deteriorate. Losses occur in high and low frequencies. There is actually some ringtones on cell phones that people my age cannot hear, and students will have that in the class, and it'll ring. Teacher does not hear it, but the students do, and they're all laughing. After age 55, hearing loss accelerates. Both primary aging and secondary aging effects occur. Environmental noise, you know, all those days standing at a concert in front of the speakers, environmental noise can hasten the loss of hearing later in life. So think about that as you stand in front of the speaker. Stop and think, why is there a different stereotype about the use of glasses versus hearing aids? Of course, glasses are more common among all age groups. Hearing aids, not so much. Fill in the blank. No single variable affects the quality of life in middle and late adulthood as much as our health. That affects our quality of life. When you're not feeling healthy, your quality of life goes down. Let's talk about cardiovascular disease. It's a process in heart and circulatory system that accounts for 27% of yearly death. Myocardial infarction and arteriosclerosis is the majority of Americans have at least one risk factor, and these risks are cumulative. Available laboratory tests measure levels of C-reactive protein, or CRP, in the bloodstream and can indicate that an individual has an undiagnosed buildup of plaque in his or her cardiovascular system. Not very good. Leading cause of death in the United States. The majority of Americans have at least one risk factor. Okay. The more risks you have, the higher risk you have for heart disease. However, rates have recently dropped. Now, the word arteriosclerosis, this is when your arteries become clogged with plaque, and clogged arteries can cause heart attacks and stroke. Not fun at all. Friedman, Roseman talk about personality patterns and how this affects coronary disease too. The type A personality is a higher frequency of having coronary heart disease, and it's because of their personality being very competitive, striving for achievement all the time, sense of urgency. They may show hostility or aggressiveness. They may compare themselves to others and be really concerned how they compare to others, and they may have more frequent conflict with coworkers. The type B personality, on the other hand, is less hurried, more laid back. There's also a type D personality, and this is characterized by a tendency towards negativity. Such people may experience stress, anger, hostility, tension, and other negative feelings and distressing emotions. However, this personality type is often characterized by low self-esteem, social inhibition, and tendency towards depression. Wait a minute, did you say type D? Yes, it's a chronic pattern of emotional distress combined with the tendency to suppress negative emotions, and depressing negative emotions leads to depression. Here are some risk factors for heart disease: smoking, high blood pressure, weight, overweight, cholesterol, inactivity, diet, poor diet, alcohol use, abuse, heredity, and page 384 has that table. Next, let's talk about cancer. This is the second leading cause of death for adults 45 and older. See the right-hand column on page 384 for cancer risk factors. Risk factors are similar to that as for heart disease. Establishing and maintaining good health habits early on reduce risks. The role of dietary fat is a controversial risk factor. Several types of cancer are caused by infectious agents. For instance, HPV is linked to cervical cancer. The Epstein-Barr virus is associated with ear, nose, and throat cancers. And the Helicobacter pylori is implicated in many studies of stomach cancer. And there's a nice little video here about prostate cancer. Men's life expectancy is less than women's. However, many women's health issues can be attributed to childbearing. Women's life expectancy is greater than men's. However, women have more diseases and disabilities that limit daily activity already present in early adulthood. This difference grows larger with age. Men die of cardiovascular disease at higher rates than women. Women have a greater ability to recover. Women recover higher levels of physical functioning from heart attacks than men do. So women live longer, however, men's overall health tends to be better because of they don't have to have babies. Social class is a more significant predictor of health variations in middle age than any others at adult ages. Occupational level and education are the best predictors of health. So if you want to be healthy, have a low stress job or a challenging job, but not that stressful, and get a good education. African Americans have shorter lifespans than whites. I don't know if it's because of social economic or because of stress and discrimination and environmental influences. Okay, cardiovascular disease is much higher in minorities because they have more risk factors that are listed in 15.2, table 15.2. Cardiovascular disease disables or kills high proportions of African Americans, Mexican Americans, and Native Americans than either whites or Asian Americans. Among women, obesity is a major leading factor. Among men, hypertension is a key risk. Also, men making comments about women's obesity is a major factor of death. I'm just messing around. Okay, next one. Diabetes is growing for all racial groups to epidemic proportions. Minorities, again, have more complications with diabetes than whites. They tend to develop the disease earlier in life. They tend to have less access to regular health care, partially because they have less health insurance. They tend to have higher risks than whites, and they tend to have higher risk for diabetes complications as well. And here's a nice little video here on coping with diabetes. Cancer. African Americans have higher rates of some cancers and poorer survival rates. Prostate cancer, colon cancer, lung cancer. African American women have higher breast cancer rates. Asian Americans have higher rates of liver cancer. Minorities fail to receive routine screenings. Okay, next is alcoholism. Between ages of 14 and 24% of U.S. adults report alcohol problems at some point in their life. Long-term drinking harms the brain, the heart, the liver, the digestive system. It increases the risk of death. Some effects of alcoholism are reversible if the individual stops drinking. 2 letters here, AA is a very helpful support group to stop drinking. Next is internet addiction disorder, IAD. The person must demonstrate a pattern of internet use that interferes with normal educational, occupational, and social functioning. It often involves a disorder of impulse control. So a lot of people who are addicted to the internet may also have a compulsive behavior disorder. But it could also be part of what's included depressive behavior. Treatment approach is involved what's called acceptance and commitment theory. When you name the problem and make a commitment to set some parameters in your life. In your view, why is the internet a more attractive means of escaping than such as books, movies, and other forms of entertainment? And how can research determine whether depressive symptoms drive internet use or spending a large amount of time online produces such symptoms? So in other words, does depression cause people to sit on a computer or on the internet, or because I'm on the internet so much, it's getting me depressed? So which causes which? Next, adults have large bodies of skill and knowledge and can compensate for some of those cognitive losses. As we get older, as we start losing some of our abilities, we can compensate more because we're skilled and full of knowledge and powers that far surpass others. Denny's model, physical and cognitive aging. There's a typical curve of age-related changes. Effects of exercise, of the skill or ability are involved. Underlying age-related decay curves. Let's take a closer look. Take a look at this chart, figure 15, page 390. Denny's model suggests a basic decay curve and a fairly large gap between the actual and level of performance on exercised and unexercised abilities. So on nearly any measure of physical and cognitive functioning, age-related changes follow a typical curve. Now notice the upper one is those who exercise regularly, and unexercised skills are much lower. Okay. The height of the curve varies based on the exercise of the skill or the ability. And the more fully one exercises that skill or ability, the higher the peak performance. There's an underlying decay curve related to age. So notice we tend to peak out at around 30 physically and cognitively. And then there's a steady decay from there on. But this term is if you use it or lose it. If you use it, you will have a higher level of performance throughout. Next is Bulte's and Bulte's model of selective optimization. Physical declines of middle age create selective optimization with compensation to combat the effects of aging. For instance, we tend to be selective to minimize distractions, we optimize our strengths, and we use those compensatory strategies, which is like wearing reading glasses, which I should be doing right now. Looking at research from Warner Shea's analysis of the Seattle longitudinal study in 1983, exercise data comes from the effects of exercise on Harvard alumni. Subjects who had cardiovascular disease showed earlier and larger declines on intellectual tests. Even adults on blood pressure medicine have declines in functioning. Exercise lowers our mortality risks. Physical activity may also help maintain cognitive functions. So go out there and exercise, and that'll keep your functioning level superior compared to someone who doesn't exercise as much. Next is memory. It's the subjective experience of forgetfulness. There's a lack of mental exercise tends to be correlated with declines in memory and cognitive skills, but major deficits are not found until the age 60 to 65. Subjective experience of forgetfulness increases with age. Middle-aged experts are proficient at overcoming perceived memory limitations. They develop cognitive strategies to buffer the effects of aging. Visual memory is the ability to remember an object you have seen for a few seconds. That also declines in middle age. Performance on remembering lists of words declines also after the age of 55. So you have what's called your episodic memories, which is your recollections of personal events. Middle-aged people use cues to help remember. Where did I put my car? Semantic memories involve general knowledge. Episodic memories slow with age, but not semantic memories. Now, practice helps maintain or gain a skill. Use it or lose it holds true for cognitive skills. Expertise in a particular field helps compensate for age-related deficits in cognitive functioning. Middle-aged adults use different strategies than younger adults to remember expository text. Declines in math skills related to speed may be most susceptible to age declines. Finally, your creativity. Simonton looked at creativity and productivity of thousands of notable scientists. What did he find? He looked at their first significant work, their best work, and their last work, and he found out that thinkers produce their best work at around age 40, and they publish their most outstanding work in their 50s. So what will you be doing when you are 40 years old? Goldman's stages focuses on divergent thinking, another creative thinking. We tend to generate multiple solutions to problems, and it often arises from cognitive bits and pieces that we mull over time. So usually we have what's called our preparations, and then our incubation period where we mull over it, and then the illumination or the aha moment, and then we translate it to our research and communicate it to other people. So, maintaining the creative edge at midlife and beyond, it's a creative process. It's a highly individualized intellectual activity. Each creative person, in one way or another, recognizes the value of accumulated knowledge and experience. Um, the key is maintenance and productivity, being consciously aware of one's own creative process and accepting its boundaries is crucial. Demonstrating some degree of humility, a sense of indebtedness to those who have contributed so far, and supporting one's creative development appears useful. This ends our presentation, and have a great week.